What factors should be considered when stratifying a patient as high risk or standard risk?
There's a lot of different biologic features that determine risk. People who have disease outside the bone marrow presentation have a higher risk. Patients who present with kidney impairment that doesn't reverse have higher risk. Patients who do not respond to first-line therapy have higher risk, and patients whose disease comes back within 1 year of starting therapy have higher risk. Having said all that about those clinical variables, in which age is included as a higher risk feature, most risk systems that physicians use in myeloma are biologically based. And those 6 biologic variables are beta-2 microglobulin, albumin, LDH, and the 3 genetic abnormalities, -17p, 414, and 1q+. And I think those are factors that each patient needs to understand if they want a more in-depth grasp of how physicians are perceiving their disease activity.
Risk stratification in myeloma means can we determine who's going to do well with our treatments and who's not? So usually there's different ways of doing it, but high risk and standard risk is one way. Back in the day, there was the ISS paper, which used beta-2 microglobulin and albumin. So that was the stage 1, 2, and 3. And then that was reiterated with the addition of LDH and FISH. And that was also stages 1 through 3. JCO 2022, they incorporated chromosome 1 abnormalities. And so now we have 4 different categories. So basically, these are the ways we've classified them, of which some people refer to risk with these things. Some refer specifically to genomic risk, like your cytogenetics FISH. Some refer to clinical risk, like extramedullary disease, plasma cell leukemia. And so those are the different ways of looking at risk at baseline.
An important aspect of making a long-term plan for the management of multiple myeloma is to establish what we call risk classification or stratification. What we mean by that is that we like to study the cells, the myeloma cells, and their biology and primarily their genetics to see if they would be a form or a flavor of myeloma that turns out to be more aggressive. And we have a number of markers we look for when we test those bone marrows, looking for these risk markers. These risk markers include some of the translocations, chromosomes 4 and 14, 14 and 16, 14, 20, but also we know abnormalities of chromosome 1, particularly many extra copies of chromosome 1, the long arm of chromosome 1, or the lesions of the short arm of chromosome 1. Those seem to be associated with more aggressive myeloma. And last but not least, and very important, the abnormalities of chromosome 17. There's a gene there called p53, which is called the guardian of the genome. So if that gene is gone, then the cells can mutate more. So those are things that we look for very carefully as we do this risk stratification. It is critically important for patients to know that being high risk is not 100% determinant. What I mean by that, it doesn't say that if you're high risk, it's game over, worthless. No, we can still have very good outcomes with high-risk disease. We'd rather not see those markers, but you can still have very good outcomes. And in fact, I can think of several patients of mine who had the high-risk markers who now I think potentially are cured because they're many years out without evidence of detectable disease. So it just should be a reminder to pay more attention, to think about perhaps more intensive strategies, but it's not 100% determinant of what will happen.